It's absolutely lovely to be here. Thank you so much for the invitation to talk, and I do apologise for not being able to be present for this, what's to be a very exciting time for Canberra. I have been chatting with a lot of your colleagues from Canberra all through the RCH and the Parkville implementation, and I'm really excited that you've been able to take on Epic as a vendor to implement, and also where needed, we're more than happy to provide assistance to ensure that you do a better job than what we believe we did. So thanks for listening. Hopefully these will go across. Okay, so just for those you don't know, Royal Children's Hospital. Now, I'll give a bit of a perspective of the Children's Hospital, but a lot of what I say will be relative also to the Parkville precinct. For those of you that don't know, we've just implemented across the Parkville precinct at the Children's, the Royal Melbourne, the Women's and Peter MacCallum Hospital. And what we've done there is shared an instance of, or the RCH instance of Epic, and we've rolled it out across the 4 hospitals, and that went live in August last year. Some of the data that I'll share is based on the Children's Hospital experience. We haven't really been live long enough across the precinct to share their information, and again, that will be up to them to share it once it comes forward. So the Children's Hospital is a biggish hospital, 340 beds. We've since increased to 65 hospital in the home beds, have about 48 to 50,000 inpatient episodes a day. We have up to 85,000 emergency department presentations, operations around 20,000 a year, and lots of ambulatory attendances, many staff. And we needed to transition our paper-based hospital onto an electronic system. Now, this will be very familiar to all of you, and I heard Keith talking about medication errors, and when you see the medication chart just below in the middle, and also the operation notes there, is it any wonder that we continue to have errors? The nursing workspace above was where medications were administered in amongst all of the paper charts that were required. Now, when we went live in 2016, prior to this is Michael Marks, a paediatrician, and the interesting thing about this picture was that his arm is resting on a single patient history, a very chronic patient of ours, and we needed to do something from an electronic point of view so that this wasn't an ongoing issue. So you can appreciate the difficulties in transitioning from a largely paper-based system, and really we couldn't possibly go back to working in this way. It's almost an unacceptable way of working these days, and I look forward to many other hospitals being able to transition to an electronic record. Sorry, oh no, there we go. So really the principal reasons for implementing an electronic record, and I have no doubt that these will be very similar to the ones that you have chosen. We wanted to improve clinical care. We wanted to make sure that patients were safe, and I heard Keith talking about some issues that, well, in fact, many hospitals experience with medication errors, and we need to try and eliminate these. We also want to ensure that patients and family were engaged more. We wanted to increase our throughput. We wanted to make sure we were an efficient hospital. We wanted to be able to support research, but we also had to be accountable for our financial performance. So all of these things, all of the research that we had done ensured that our financial performance would improve. Some of the guiding principles that we put together, now the little triangle down there you see on the right-hand side of the screen is really the triangle of care that we believe in and practice at the Children's. We wanted to have excellent clinical outcomes. We want healthcare to be a positive experience, timely access, zero harm, and it's got to be sustainable. So in implementing our electronic record, we also wanted to make sure that we had evidence-based practice so that we could deliver the safest possible care. Evidence shows that standardising practice also is safer for patients, and we all know that there's much variation and duplications across hospital, and having the EMR platform gives us the ability to reduce that. The system had to be easy to use and certainly had to drive efficiency and reduce waste in the hospital, and certainly supporting clinical effectiveness and research, as I've mentioned previously. So April 30th, 2016, RCH went with a big bang implementation. In August 2020, Parkville had a COVID implementation where they went from paper to Epic, and the big difference there was that they were in the middle of a pandemic, and there was a period of time where we didn't really believe that we could deliver the product. A lot of the back-end work was done, but the logistics of implementing an EMR in the middle of a pandemic was very confronting, and but was achieved successfully with no issues regarding transmission of infection. So we're hoping that the Canberra implementation looks a bit like this, where you transition from paper. Yours is the immunisation implementation, and many of the benefits that Epic have in terms of infection control practices. They've got a module that you're getting, I think, called Bugsy. All of those things are going to be highly relevant to the way in which you'll roll out Epic in the coming months and years. Just a little bit on what we implemented and what were our success factors. This is pretty well a standard implementation approach where you'll be in the discovery and education phase, I suspect. As I know that you've started to employ people, and a lot of legs are hitting the ground now, and this is really preparing the hospital for how you might approach an EMR implementation. Now, this is relatively standard methodology for project rollout for an EMR, with a few minor variations, but certainly these phases that we went through were very sound in their logic. They were evidence-based, and can certainly say that with the help of Epic, we stuck to these religiously. Project governance, this is probably the most important aspect to the project, where you set up your governance structures to ensure that what you say you will do, and that people within the hospital will follow through on the things that need to be done for implementation of an EMR. This is an absolute transformation of the way in which you work. The way you currently practice will be completely different the day you turn on your EMR. But there's a lot of preparation to make sure that you are all on the same page, that you're all working towards a common goal, and that you can also sustain the effort involved to maintain an electronic system to ensure that it delivers all of those requirements that you first set out to do. So governance, and I know Peter O'Halloran and colleagues have set up a good governance structure. They have been down to visit us a few times, and hopefully we've been able to pass on some tips that will be helpful for your implementation. Again, all of the different committees within the hospital need to be buy into the process of the governance. So we have many great care committees, as we call them, on governance, consumerism, medication safety, etc. All of those need to buy into the new way in which you will now work when you implement the EMR. And everybody needs to change the methodology of what they do so that they can feed back into the electronic record and ensure that you get the benefits that you're looking for, both patient safety benefits and certainly financial benefits. So some of the success factors we realised from our project, and also from the Parkville project more recently, is that we were adamant that it was not an IT project. Of course, it is an IT system, but it's got to be implemented for the right reasons. And changing the way in which we work from a clinical perspective is the most important reason why we do this. Some of the success factors of our team were that many of our analysts were clinicians, which was very helpful in terms of analyst training to understand the EPIC system, and now we can go in and change that system through our governance structures, but we have an understanding of what is required for the lowest common denominator that will use the system. We did need to externally recruit others from outside the organisation, which I know you have done, to fill some of the skill gaps. We had a very big emphasis on training, which was mandatory, and that was supported by our CEO. And it's interesting, we were able to reduce our training requirement pre-EMR from around about 8 to 12 hours, and now we have a 2-hour online session where required. So once there's a body of knowledge within the organisation, training becomes very simple, and we're happy to share our experiences with that as well. We had very strong support from our vendor, both on-site and off-site. They have a support model from Verona. Now, in the COVID world, that's going to make it a little bit more challenging, but I think certainly I think of only 2 hospitals that went live during the pandemic. We were able to prove that remote support can be done, and it can certainly deliver a successful implementation. We're hoping that that's not the way that you have to go, but be reassured, any anxiety that you have around that, it can certainly be accommodated by the vendor and also your project team. We've spoken about governance. Interesting, very important when we first went down the EMR line was to make sure that we engaged with all of the medical, nursing and allied health and also non-clinical roles to ensure that they understood the implications of the electronic record, what it would bring to them, and also what they wanted it to bring to them so that we could build it in. Benefits tracking, again, everyone in this day and age needs to be able to pay for their system, so we had very robust benefits tracking, both on staff satisfaction, and we've just completing another survey on staff satisfaction. Need to make sure that we can pay for this in an ongoing fashion and that it's good value for money. Make sure that we stuck to budget, which we certainly did, came in on budget and on time. That we become more efficient as a hospital, which is one of the guiding principles of what we want to do in the first instance, and ensure that quality and safety standards improved as well. Just in terms of staff satisfaction, and again, this is from a children's hospital perspective, and this was relatively early on, but we were able to show that as we moved, the further we moved away from go live, the more satisfied staff became. That had a lot to do with on-floor support, the training that they received, and also the support that we received from EPIC to respond to any issues that might arise along the way. And that staff satisfaction continues. We've had a reduction in the numbers that have participated in the recent survey, but certainly we're expecting very similar experiences. Operational benefits, and certainly in the 8 quarters before and after EPIC EMR implementation, we had an increase in admissions of 8.2%. That's for many reasons, but certainly we were able to increase capacity through the efficiency of the electronic record. Outpatients, we saw a 21% increase in outpatient attendances, again, all through the efficiencies of the electronic record. ED wait times, interestingly, despite having increased numbers, we were able to improve our ED efficiency by around about 21%, where the wait times went down in our ED. So other things that improved were waitlist management, reduced significantly. Again, this isn't in COVID times. We haven't looked at the results from that as yet, but certainly in a normal environment, the waiting times for your list should reduce. Telehealth had a significant growth. Now this is pre-COVID, so just through the implementation of the EMR gave clinicians the ability to increase their use of telehealth. It will be very interesting to see. In fact, we're probably 80 to 90% of telehealth visits currently, or certainly post the acute phase of the lockdown. So the clinical benefits that we received, and we've all seen evidence of this, is that we have a single system where all of the information is in one place. It gives us a clear overview of the patient where I can look on my mobile phone or my tablet and I can see all of the relevant information that I need to see from the patients that I'm caring for. And that goes from a nursing perspective, allied health perspective, and also a medical perspective. Things are easy to find. Once you're used to the system, it's very easy to find the information that you need. And Epic over the years continues to improve the interfaces. They continue to improve the user interfaces so that things become more easy to find. The system is extremely fast. We very rarely have performance issues. We had some performance issues in our transition over to the Parkville precinct where we went on to a common network, but those issues were identified quickly by the technical team and we're back up to very high performance access to our EMR, both on mobile devices and also desktop and network devices. You want to aim for 100% uptime. We have had very few unscheduled downtimes, had some very early in the piece, another one late last year, but this minimally impacts, and people are so well drilled at a downtime. People don't panic, they get on, they document on paper for the short period of time, and then information is then back entered into the EMR. So it has virtually no impact on a day-to-day basis, and certainly haven't been down for more than 10 hours. I think it might have been the most time that we were down. And they were due to hardware failures rather than issues with the database. You can have multiple concurrent users, so capacity is not an issue. You know, you can be confident that the technical team and the project team will ensure that the number of concurrent users are licensed appropriately and so that you can all get the information that you need. And certainly things like device integration has been a significant boon for people in critical care areas, operating theatres where the task of entering data on the half hour or the hour just no longer needs to exist. All the information is pulled directly from the patient monitoring or ventilation and is pulled straight back into Epic and available for recall at any time. And as I mentioned, we all have the ability to have remote access. It's been was very helpful during the COVID lockdown where many clinicians chose to do telehealth appointments, work remotely, and many staff from the children's also work remotely. Interestingly, from a patient safety point of view, the efficiency of the way in which patients were monitored within the EMR, where we had what we call the Victor charts or the MET notification, given the visibility of the observation charts, we had an increase in the number of MET calls, which is exactly what you would want. You want to be able to see that patients are deteriorating. And into the future, we'll be looking at integrating alarm systems into the EMR so that we can push notifications to the patients of when a particular patient is deteriorating. Now, again, we don't attribute all of this to the EMR. Many things have happened that may contribute to a reduction in mortality, but certainly we noticed in the quarters pre-EMR and post-EMR that we had a 22% reduction in standardised mortality rate. So just wrapping up a little bit here, just from the Canberra experience and from my understanding of what you will be implementing in Canberra, certainly with your patient administration system that you're implementing, Grand Central, this will significantly reduce the number of interface issues that you may have had or that we have previously had. And we look very much with interest on how the PAS is implemented, because at some point in time we would like to utilise the PAS as well from Epic. Once you have everything integrated under the one system, it makes Epic flow seamlessly. Same can be said from Beaker, which is the integrated laboratory system, and that's heavily dependent upon the patient administration system to reduce interface errors and ensure notifications and laboratory results get to the right person at the right time. This will be a huge advantage for Canberra, and again, we look forward to you implementing Beaker and also the PAS. As I mentioned, the information will be pushed to you just as it is us, but you'll have hopefully a more seamless experience. Secure Chat has been, we turned Secure Chat on late last year, and we have had a significant transition away from paging, whereby staff can communicate within the context of the EMR and within patient context. That allows you to discuss a patient within Secure Chat. You can and nominate anyone that you would like to discuss it with. So we see a lot of scope for Secure Chat within the EMR that you will also benefit from. I understand also that you have SpectraLink devices up in Canberra, and I'm currently project managing the SpectraLink devices down in Melbourne. They've been a huge boon for mobility within the children's and certainly across the Melbourne and also the Women's Hospital, whereby nursing staff can do their medication scanning, they can identify patients, they have all of the things that they need to do most of their clinical work. And with many of the functions that Epic are bringing out, such as the nursing hub on the Rover application, we see mobility as the way of the future for all healthcare professionals. So what can you learn from our experience? First off, be reassured it's been done many, many times before, and it's been done successfully. Where it hasn't worked successfully, it's usually because the recipe hasn't been followed. But you can certainly be reassured that the vendor pretty well does everything that they say they will do, and they assure delivery of that project. Just be mindful in the early stages that this is the first day, or this is the start of your journey for EMR. It's not the end of the journey, and trying to perfect the system in the early stages means that you may lose sight and try and overreach for the things that you're trying to achieve. The obligation of the project team is to deliver a system whereby it is safer for patient care, it is more efficient, and you can do your work. It is unrealistic to think that any project team can deliver the perfect system up front. And the perfect system evolves over time if we ever get there. But it's a journey that you go on with your EMR team as well as the vendor that's supporting you. This will absolutely unify all of your hospitals that you're planning to implement with a common goal. The camaraderie that exists across the Parkville precinct with hospitals that knew each other existed but rarely spoke. We have very good relations with all of our Parkville precinct hospitals. We have a very robust and good decision-making clinical council that ensures that the clinical decisions that are required for the EMR are made at a consultative level across all 4 hospitals, and that is one thing that will ensure the success and ongoing collaboration between all health services. you're in the very early phases, so you need to develop a philosophy of build. How do you want it to be for you in 5 and 10 years' time? And then work towards that. 4 years ago, when we implemented, nearly 5 years ago, we had a build philosophy that was had to be simple for the users, probably less focus on mobility at that time, but certainly I see the way of the future, particularly with pandemic impacting on people and the increase in hospital in the home services. We have a big push now for mobility to ensure that people can travel lightly and still do all of the work that they need to, and still be in touch with the hospital with the people that they need to. You do need to follow the national standards, and they're a very good blueprint for the way in which we should be practicing. And standardisation certainly helps all of us come together in a common fashion to ensure safety of patients. Probably the one biggest thing, and I mentioned earlier that you can certainly trust your vendor and you can certainly trust your project team. Change management of the staff that you're working with or in charge of can be a difficult thing. We had a pretty simple philosophy in terms of trying to handle people that may have been a bit resistant to change, and we said that there were 4 pillars of why we were implementing the electronic record. One was of patient safety, of which it's very difficult to argue that people don't want things to be more safe for patients. Everyone pretty well agreed that national standards were what we practice by. We're also governed by legislation. Everyone felt that standardisation was a good thing, and certainly having an evidence-based way of managing patients, and certainly at the Children's Hospital we were blessed with having very good clinical practice guidelines, and we were able to embed them into the EMR. Now, from a change management perspective, when people are resistant to change, once you put those arguments to them, then it's very difficult to argue against not putting in an electronic record, other than, and really the things that you need to do are to ensure that you support people in the transition to an electronic world. So the lessons learned from both the Children's Hospital project, the Parkville project, I was over at Great Ormond Street a couple of years ago for their project, and all of them have a very common theme. It's got to be framed as a clinical project, even though there are large elements of IT that is required. That is to support the infrastructure, but it's got to be sold to all of your staff as a clinical project. You're doing it for the safety of the patients and the efficiency of people and the way in which they work. You need to send that clear message to all clinicians, and they will help you drive that project. You've got to ensure that clinicians are engaged and that you continue to reinforce the message for all clinicians based on those principles that I just mentioned previously. And make sure that your clinical counsel takes ownership of the direction of the way in which the electronic record should function. Again, we had an independent review by Ernst & Young from the Children's. I don't think that's happened as yet at Parkville, and some of the success factors that were shared by Ernst & Young during their audit was that it was a highly engaged and visible executive sponsorship. So look to your leaders for directing you through the myriad of change that you're about to go under. Ensure that your clinical leaders have consistent and active engagement across all sectors of the hospital. The users must want the system from the beginning, and I have no doubt from my interactions with Peter and his team that Canberra is well and ready for a new way of working, what is probably the only acceptable way of working in a healthcare setting. I know that you've set up right for the project by all the work that has gone in. You have a methodology that has worked both in Australia There's been much Australianisation that's happened, and it's also worked overseas very successfully. I know that you've got the project director and the managers. The commitment and goodwill of the team, we have already shared some of the staff members that were on our project team, and I know that there's no greater feeling than participating in a project of this size to deliver such a great outcome for so many people. And I know all of them will share that same enthusiasm with you. Again, we've mentioned that committed to the outcome with the vendor, and I know that you've all planned relentlessly for the way in which you'll function. So hopefully I've covered all of the things that I needed to, and I'm happy to take any questions.
Look, thanks for that, Adrian, and certainly I can attest that the team at Parkville, and particularly Adrian and those at the Royal Children's, have been incredibly generous with their time. I think we've been down a few times now and asked questions and gone backwards and forwards on all sorts of things, and it's amazing to see what's occurred there. A couple of quick questions that are coming in. Adrian, would you agree that to avoid medication errors, we must trust, integrate and share public and private and consumer data that exists in disparate systems?
In principle, yes, I do agree with that. I think getting that to happen long term, I mean, the EPIC system will be an ecosystem for your hospital, but it's a receptacle for interfacing all of the external systems to ensure that that can happen. So I have no doubt that over time, of all of the EMR vendors that we've seen and looked at, EPIC has the capacity and the will to have connected healthcare, and certainly the technical challenges of interfacing with some of these other feeder systems, certainly EPIC and the technical team will be able to overcome. Interestingly, during the RCH implementation, the most difficulty we had implementing was with the My Health record, but that was done successfully and is being utilised at this stage. So I would definitely reinforce what you said about bringing as much data as possible into EPIC as we can. Mindful that hospital systems aren't statewide systems or territory-wide systems, and I know a few overseas hospitals or overseas countries such as Finland and have looked to implementing EPIC on a broader base across states. Interoperability is able to be done, but sometimes it's not always in the interests of the vendor to do it. So that's something that we need to work on.
Wonderful. I've got a question from the audience here. Nick Coatsworth, over to you.
Is that working? Yeah. I'm not being the annoying guy that hogs the mic.
Not yet, anyway.
Not yet. I got a text from our CEO, Bernadette McDonald. Adrian, thank you very much for that presentation. Would you mind just expanding? You gave some very clear metrics there on MET and mortality. What other things have you noticed in terms of patient outcomes, safety, and also patient experience? Have you had anything in the latter that EPIC's helped you identify?
The last bit first on patient experience. Interesting, the uptake of the RCH portal, or the My RCH portal as it's called, is a means by which patients can interact with their own health record. I can't recall the exact numbers off the top of my head now, but I do know that for our chronic complex care patients, we have a significant uptake of them using the RCH portal. So the platform for EPIC to provide information to families and patients is unsurpassed, really. It has all of the functionality. We haven't even turned on half of the functionality that is possible in the portal. So it's certainly of benefit to patients and their family, and in our cohort of patients, particularly the complex care patients, it's been very beneficial. In terms of patient safety, the the things that we've noticed, and again, you know, we're not saying that the EMR is solely responsible for the improvement in deteriorating patient. I think it provides us with a platform to give people an awareness that they can easily look and review at what's going on with patients, whether that be in terms of the acute deterioration or whether it be in terms of us being able to review and audit what went on with a patient where there may have been an adverse event. It's giving us much more visibility of what went on. It's giving us timestamps of what went on. So it enables us to review patient instances, and we're not saying that they're all going to go away, but certainly in terms of sentinel events, we've had a reduction in those. And we've also had a greater awareness of staff that I, as the nurse looking after a patient, can either communicate via secure chat to get the doctor that I need quickly, or to ring them up on their mobile device. I can, the clinician can directly look at what's going on with the patient, and the other important thing is that the MET modification the Victor charts that we have, whereby we have the ability to set a threshold for what would be normal for a patient or a particular patient, and that may vary whether you've got congenital heart disease or you might have a respiratory illness. Our ability to finely tune that or really personalise that care for that patient gives us the ability to be alerted when that particular patient, regardless of what their condition is, may deteriorate. So there's the EMR gives us the awareness that we can easily look to see what's going on with the patient. The decision support, and I remember from Keith's presentation earlier about allergies, that, you know, very rarely that we would have any allergy issues, you know, because the alert comes up all the time. So there's many things that contribute to the improvement in patient safety. It's not all just the EMR, but it's certainly an awareness now that people have the information at hand, that the EMR will support the decisions that you make or support the indecisions that you make. I think all of those contribute to an improvement in patient deterioration. And sorry to go on with it, but I think there's many other things that we can use Epic for, and certainly push notifications of a deteriorating patient, which is possible. Haven't done it as yet, but we're looking to do that in the next 12 to 18 months. So lots of things that are going to improve the deteriorating patients' outcomes.
Wonderful. Look, thank you for that, Adrian, and thank you for taking the time to talk to us this afternoon.